Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
When a child can't stay awake in school, falls asleep mid-sentence, or experiences sudden muscle weakness, it's not always just fatigue. It could be narcolepsy. But getting to that diagnosis, well, that's where things get complicated. This is Unscripted, the AMCP podcast, and I'm your host today, Amy Lugo. Joining me today is Dr. Joshua Lennon, assistant professor at the University of Tennessee Health Science College of Medicine in Memphis. Dr. Lennon has over a decade of experience treating all aspects of sleep-related conditions for adults and pediatrics. Dr. Lennon, welcome to Unscripted. We are really glad to have you.
Thank you, Dr. Lugo. I appreciate the invitation from you and the AMCP, and I'm excited to have a discussion today about narcolepsy in kids.
Awesome. Well, today we are breaking down the journey for children and their families from those early, often confusing symptoms through the diagnostic odyssey that many families endure, all the way to the newest treatment innovations and what they mean for real-world care. So let's dive in, and let's start at the beginning, Dr. Lennon, with recognition. For many of us in managed care, we think of narcolepsy in adults, but narcolepsy frequently has its onset in childhood or adolescence. Dr. Lennon, can you walk us through how narcolepsy actually presents in kids, and is it the same picture we see in adults?
Yeah, that's a great question. It turns out that the basic fundamentals of narcolepsy are really pretty similar, whether it's a child, an adolescent, a young adult, or an older adult. But just like with the adult population, often the problem that we see in kids is that there's a long delay between the onset of symptoms and the recognition and the complete diagnosis actually being finalized. And part of that has to do with the ability for us as adults to recognize what's going on with the child, or for the child to articulate it. But it really comes down to these four basic symptoms that most people with narcolepsy will have some combination of them. Everyone universally is going to have excessive daytime sleepiness. That is the cardinal feature of narcolepsy, whether it's in a child or an adult. The second would be the sleep-wake phase transition hallucinations. So these can either be when we're first falling asleep or upon waking up, where we're hearing things, we're seeing things that aren't really there. It can be really kind of confusing. Seems like you're kind of dreaming when you're awake. The third feature is going to be something called sleep paralysis, which is where upon waking, your mind kind of wakes up, your eyes wake up. Basically, the rest of the body is relatively paralyzed and not really able to move. And this can last anywhere from just a couple seconds to maybe as long as a minute or so, but it can be really a terrifying experience where you can't really move your body. Then the fourth feature, relative to all individuals with narcolepsy, would be this disrupted sleep. It's not really an insomnia where somebody is troubled by being awake and having difficulty falling back asleep. It's more these frequent but limited interruptions across the night that can disrupt the overall quality of the sleep. So whether in a child or in an adult, we're going to see this combination of these four features among anyone with narcolepsy. The main difference between type 1 narcolepsy and type 2 narcolepsy, again, whether child or adult, is going to be the feature of something called cataplexy, which is where we have this experience often triggered by strong emotion, especially humor, laughter, strong positive emotion, really any strong emotion can do it, where you essentially lose muscle tone in the body. This could be the entire body overall, or something that might actually collapse down to the ground. More often, it could be a partial loss of muscle tone. So it could just be in the neck muscles, in the face, in the arms, or the legs. And this often may last for a matter of seconds. This can be quite distressing for the person experiencing this because they're not actually falling asleep. They're maintaining full alertness and cognition, just their muscles unable to maintain that same degree of tension. And that can lead to this often embarrassing and sometimes potentially dangerous effect of cataplexy if they're in a situation where they might be unsafe if they were to fall to the ground or not be able to stabilize themselves.
Yes, that is really striking. Wow, the way cataplexy can look so different in younger children. It makes me think it often gets dismissed or worse, misattributed entirely. What are the most common misdiagnoses that you see in pediatric patients carrying when they finally make it to you?
Well, it kind of depends on which feature we're talking about. So again, it shows that they have different sleep requirements than an adult. And so when it comes to this cardinal feature of excessive daytime sleepiness, the number one reason why that's going to happen overall is the child is just not getting enough sleep. So for a school-age child, they really ought to be achieving somewhere between 9 and 12 hours of sleep. For adolescents, it's about 8 to 10 hours of sleep. So if they're falling short of that, say, 8.5 hours for a fifth grader or fourth grader, that's probably just insufficient sleep. And so that's a better explanation, more likely, for someone experiencing daytime sleepiness. Other sleep disorders could similarly present with daytime sleepiness. So the most common would be obstructive sleep apnea. So whether this is, again, in a small child or a school age or in an adolescent, that this is often going to present with that daytime sleepiness. And again, especially the younger the child is, they're less likely to be just dozing off in the middle of the class, but more likely to display these kind of features of ADHD, more that hyperactive type, where they are trying to move around and stimulate themselves to maintain that alertness when they're experiencing that kind of sleepiness. So OSA commonly presents with ADHD-like symptoms in very young children, in an excessive sleepiness and dozing off and napping in older school-age children and in adolescents. Other sleep disorders like restless legs can commonly present similarly to narcolepsy in this age group, and insomnia as well. If someone is really struggling to fall asleep and stay asleep across the night, they're going to have this type of daytime sleepiness during the day as well. For something like cataplexy, our differential shifts a little bit more radically. And so, could this be something like syncope, right? So is this a cardiac issue? Is this related to medication that they may or may not be taking? Is this a change in their blood pressure? They're experiencing significant orthostasis or something like POTS that might be contributing to this syncope or pre-syncope presentation. Different types of epilepsy can present with atonic seizures. And so it can look pretty identical to something like cataplexy, but the main difference is going to be the retention of consciousness, which again, it can be rather difficult to tease out if the individual suffering from this is, say, 6, 7, 8 years old, that may not be able to explain quite as readily whether they are fully aware when this is happening during the event versus only being aware before and after. So those are some common things that we might see looking into the differential. And then, of course, there's all the secondary causes of narcolepsy. And so, again, we tend not to see this quite as often in middle-aged adults, sometimes in older adults, but we often see this in young children where there's some sort of CNS lesion, often having some impact either on the brainstem directly or on the hypothalamus, that could be manipulating some of these wake and sleep networks to basically cause all the cardinal features of narcolepsy. It's still a narcolepsy, but it's due to one of these other conditions. So in younger children, unfortunately, often this can be due to something like CNS tumors that might be presenting in this manner. Sometimes in adolescents, we'll see this presentation with something like multiple sclerosis impacting that inferior portion, that hypothalamic region of the brain, causing one of these lesions from multiple sclerosis to result in these kind of symptoms as well. In older adults, some autoimmune CNS conditions or strokes might impact these same networks to cause these kind of symptoms. But that's kind of a pretty broad differential of what we might be considering when someone presents to us with these types of features.
What is the average time from symptom onset to narcolepsy diagnosis?
Unfortunately, it's too long, I think, really, no matter how you break it down. In adults, most often we see an interval of delay of about 15 years or so. And in children and adolescents, it's typically around 10 years or so between the initial onset of symptoms and when they're finally ultimately diagnosed with something like narcolepsy.
Wow, 10 years is a staggering number when you're talking about children. That's most of their school years. How do you approach management in a child versus an adult?
Well, it's pretty similar. I think that the main goal, right, is function, right? Narcolepsy is not a condition that is going to lead to premature death in and of itself. There are certain comorbidities associated with it, but that's often due to uncontrolled symptoms of narcolepsy. And so our main goal is really to improve the life and function and day-to-day experience of the individual suffering from narcolepsy. And so that's primarily done by trying to provide them methods of maintaining wakefulness and alertness throughout the day. So whether this is a student sitting in a classroom, a student on the athletic field, an adult in the workplace, a parent trying to manage a household, no matter what the setting is, we want that individual to feel in control of their own life. And it takes consciousness and alertness to be able to do that. And so methods, whether they are behavioral or pharmacological, are meant to really try to improve that wakefulness throughout the day. And then if the individual suffers from type 1 narcolepsy with these episodes of cataplexy that can lead to this physical loss of muscle tone that could severely impair their ability to function, then we do have a set of pharmacological agents that can improve narcolepsy as well. Now, in children, unfortunately, compared to the wider breadth of opportunities that we have in adults on label, in kids, there's really only 4 agents that are FDA approved to treat narcolepsy with or without cataplexy in those under the age of 18. So there's kind of 3 varieties of one medication and then a single agent, and in addition, in a separate family of medications. So these are the oxybates. Specifically, there's 3 brands that have been approved. One is Xyrem. A second is Lumryz. These are both sodium oxybate. And then the third is an agent branded as Xywav, which is calcium, magnesium, potassium, sodium in alphabetical ordering. So it's a mixed salt oxybate. And so those are the 3 oxybates available. And this is for children 7 years and above. There are some weight considerations for that as well. And then the 4th agent, there's only one drug in this family of medicines, which is pitolisant, branded as Wakix. This is a histamine agent. It's an H3 agonist, reverse antagonist. And so by improving the amount of histamine available in the central nervous system, that can help support this wakeful state for these individuals. Now, thankfully, actually, all 4 of these agents, the oxybates and pitolisant, also improve not just wakefulness, but cataplexy as well. And so when we are trying to select a particular agent for an individual, trying to get the most bang for your buck is really important. So rather than trying to choose 2, 3, 4 different agents to tackle these symptoms, if you can get away with just one intervention and resolve, ideally, if not improve these symptoms in that individual with one drug, then that's really the goal.
You mentioned pitolisant. I wonder if you could just start with that one in terms of where it fits in this patient population.
Yeah, so pitolisant is approved for children 6 years and above, which is really helpful. Again, there are some weight considerations for which max dose we're going to use. As a histamine drug, just like a lot of our antihistamine drugs, we have to be concerned about QT prolongation. And so there are some considerations there, which are really uncommon in this population. But with pitolisant, branded as Wakix, this medication is going to both improve daytime alertness as well as improve episodes of cataplexy. In fact, what we see with several of these drugs is that one of the most common side effects, these unwanted adverse impacts of these medications, is insomnia. And so when you have a medicine that's really good at improving that alertness throughout the day, so much so that even 12, 14 hours later, that individual, might still be so much awake that they have a little bit more difficulty falling asleep, that tells us how potent some of these agents can be. So thankfully, with something like pitolisant, this is the only medication that's FDA approved for adults or children for narcolepsy that is not a controlled substance. And so if there's any concern about an individual with comorbidities or concern about abuse potential, and something like pitolisant kind of eases a lot of that concern from the prescriber or those filling these prescriptions, because it's been demonstrated that there really is no abuse potential with pitolisant. So if that's a concern, pitolisant would certainly be among one of the top agents being looked at. Again, for hitting both sleepiness and cataplexy and the tolerability of the medication and that limited abuse potential and not being a controlled substance.
Right. So from a managed care perspective, that controlled substance piece is not trivial. And we see access challenges, prior authorization layers, step edit requirements. Is the complexity of the REMS program around sodium oxybate a real world barrier for your pediatric patients?
I think not. In my experience, it is a very simple process to apply for and to be approved. And I think for patients and their families, they actually appreciate it, knowing that, especially the oxybates and the potential for abuse and misuse with those drugs, to know the surveillance that's happening. Again, it's nothing that's really too onerous. It's usually monthly check-ins. It's usually getting a heads up that a delivery is coming. But thankfully, the REMS program is actually made to be very user-friendly. It hasn't really been, in my experience, a disruption between your diagnosis, a prescription, and someone actually getting treatment.
Let's shift to where the science is heading. Orexin receptor agonists represent what many are calling a paradigm shift in narcolepsy treatment, directly addressing the underlying issue in type 1. How do you see this class reshaping the landscape, particularly in peds?
These orexin drugs are really going to be game changers. The pathology of type 1 narcolepsy is defined by insufficient levels of this hormone. So being able to replicate its effects is really effectively a cure for type 1 narcolepsy. And we're seeing similar effects in type 2 narcolepsy as well. That there's been a number of these agents that have been tested over the years. Typically, we're going to see a lag between when these things are looked at for adults versus children. So it could be a number of years before these things are actually on the market and available, FDA approved for population under the age of 18.
Yeah, that mechanism story is compelling, how it really acts on the underlying problem, especially for families who understand that narcolepsy type 1 is fundamentally a loss of the hypocretin neurons there. That idea of restoring that signal rather than working around it is a different value proposition entirely. But with any novel therapy, we know access doesn't automatically follow FDA approval. What are you hearing from families and seeing in practice around formulary coverage and prior authorization for newer agents?
I think there's a lot of excitement as well as a lot of frustration. I think because of access issues, that there's a lot of workarounds that are required, a lot of financial aid that needs to be applied for if they're trying to get access directly from the sponsor of the medication. However, I think for the most part that children, just like adults, are getting treatment. Maybe it's not the preferred treatment, but they're getting something along the way. And even if that treatment is ultimately unsuccessful to begin with, that is just more justification, more evidence to provide to a payer to say, hey, we tried this, the preferred agent, and it didn't end up working like we wanted it to. And so now can we please have access to this initially prescribed therapy that was at first denied? And so even though that might delay things a little while, it's not delaying treatment for the child with no treatment. It's just delaying that initially prescribed therapy. And so we're not seeing a big problem with kids getting access to these medications. Sometimes just a delay in getting there.
Right. Okay. That is good news. So what about as kids, peds transition to adults as they become 18, that transition point, that's an underappreciated vulnerability, potentially a gap, right? A barrier when it comes to health insurance or coverage. A teenager who is finally stable on a regimen ages out of one formulary tier and into another, sometimes losing, the continuity. How do you as a clinician try to plan ahead for that?
So it really does allow for some personalized care, but that requires them being able to show up and to be able to take that good history, be able to understand what their needs are, both through their treatment and their lifestyle choices going ahead, as well as what their plans might be in the future, and trying to understand, what can we do now to get ahead of it so that when they do have that insurance change, or they do have that job change, or they do have that relocation, that there's not going to be that gap in care. And so when anticipated, all these problems can be fixed even ahead of time. But too often we're left with someone missing a couple of appointments, showing up a year later in a new town, a new city, delaying getting records available, and that leads to significant gaps in care for those individuals. So I think it really just requires that mindset of, hey, we see this thing coming up, let's try to get ahead of it before it really becomes a big problem.
I see. So just thinking ahead and planning ahead. So as we close out, Dr. Lennon, I want to give our listeners, many of whom are pharmacists and medical directors and formulary decision makers, a few things to take away. If you could leave managed care professionals with 2 or 3 unscripted messages about pediatric narcolepsy, what would they be?
Narcolepsy is a condition that severely impacts someone's ability to function. They're going to underperform in school. They're going to underperform socially. This leads to a lot of comorbidities related to that underperformance, whether because of missing out on life or depression that's commonly associated. When it goes untreated, weight gain becomes a big problem. So all of the features of weight gain, from metabolic syndrome and diabetes and even sleep apnea, so all these other issues can compound when that narcolepsy is not addressed effectively early on. And so we can mitigate a lot of these additional health risks and costs associated with them if we can adequately treat the narcolepsy as soon as it is recognized. And we do have a number of highly effective therapies that are available that, just because they're newer doesn't mean that they have to be better, but in many cases, especially for medications like the oxybates and pitolisant, which are particularly individually approved by the FDA to treat this population, and with a single agent can treat all these effects of narcolepsy, I think the priority should be given to these particular agents because they've actually been tested and demonstrated to be safe and effective in this population, not just for some other indication or not just in adults, but specifically for kids with narcolepsy. We know that they are safe and we know that they are effective. And so that evidence should guide decisions regarding coverage for these therapies rather than just the cost themselves, taking into consideration the entire cost of care for this individual when appropriate therapies are delayed.
Those are exactly the kind of insights that translate from the clinic to benefit design, and I hope our listeners will carry those forward. Thank you, Dr. Lennon. Your perspective on both the science and human side of this condition is incredibly valuable. And thank you to our listeners for joining us for this episode of Unscripted, the AMCP podcast. Until next time, stay curious, stay informed, and keep advocating for your patients.